تمام. معكم إبراهيم الصبحاوي استشاري كلى. So today we'll talk about the nephrotic and nephritic syndrome. So before that, we have to understand that what's the function of our glomerulus. So just you have to remember that we have what's called filtration barrier, which is consist of three important barrier. First one is fenestrated capillary, and the second one glomerular basement membrane, and the last one is the podocytes. So in case of nephrotic syndrome, the layer affected is the podocyte, the last one. So that's why we are calling the minimal chain disease and FSGS podocytopathy. So as a consequences of the podocytopathy, the patient will lose a lot of in the urine. So the cardinal feature of nephrotic syndrome is 3. Heavy proteinuria more than 3.5, and ultimately the patient will have hypoalbuminemia less than 3.5, and then as a symptoms will have the edema. Regarding hyperlipidemia, it's not important, or it's not always present in the nephrotic syndrome, but can help in the diagnosis. So another issue will have the patient with nephrotic syndrome. So we'll have risk of the thrombosis. Why? Because he is losing the protein S and protein C and antithrombin 3 in the urine. So he'll be at risk of the thrombosis, as well as risk of infection because he will have the hypoglymia. So as we said before, how we can differentiate between nephrotic and nephritic syndrome. In case of nephrotic syndrome, the patient will have heavy proteinuria, defined as more than 3.5 gram, and then hypoalbuminemia less than 3.5 gram, and edema. All of this because of heavy proteinuria. Hyperlipidemia is not important to fulfill the criteria of nephrotic syndrome. So how can differentiate between two of them? In case of nephritic syndrome, the patient will have hematuria, and most of the time will have AKI and hypertension. While nephrotic syndrome will have heavy proteinuria. In nephritic syndrome, the proteinuria will be less than 3.5, so sub-nephrotic range proteinuria. Also, the patient will have sterile pyuria, meaning that there is WBC in the urine, but there is no infection. So we'll talk about now about nephrotic syndrome. We have primary podocyte injury, as we said before. The three main causes is minimal chain disease, FSGS, focus segmental glomerulosclerosis, and membranous nephropathy. What is our epidemiology? So we have minimal chain disease present by model, so in younger patient and in children and in elderly, so less than 18 and more than 80. And in between, we have the younger patient, we have FSGS or membranous. This is about nephrotic syndrome. So what are the extrarenal clinical manifestation of nephrotic syndrome? As we said before, hypercoagulability because there is loss of a protein C and antithrombin 3 in the urine. And more, we are seeing this one more in case of membranous nephropathy. Another thing, we have anasarca because there's a fluid retention, sodium fluid retention secondary to hypoalbuminemia and increase in cortic pressure. Other thing, as we said, we have risk of infection, risk of the thrombosis. So if the patient presented in the ER with the symptoms, features of nephrotic syndrome, what we'll send as a lab, so we have to rule out secondary causes as hepatitis C, hepatitis B, hepatitis C, HIV, C3, C4, autoimmune disease, we have to rule it out. And then, of course, the diagnosis, the ultimate diagnosis will be by kidney biopsy. Okay, what about if the patient presenting diabetic patient presenting with proteinuria? When we consider biopsy, it's not always we are considering biopsy in case of diabetic patient because this is a secondary cause of nephrotic syndrome. We have to treat underlying cause first. When we consider it, if there is rapidly progressive kidney disease or something suggestive of systemic disease or positive labs, suggestive another diagnosis rather than diabetic nephropathy. Always in case of any disease, you have to first of all mention then pharmacological treatment and then pharmacological treatment. So in case of nephrotic syndrome, of course, we'll ask the patient for fluid and sodium restriction. If the patient having volume overload, we can help him with loop diuretics. to prevent the volume overload. And if the patient having hypertension, it's better to give him ACE or ARBs. For the hypercoagulability, if the patient diagnosed with membranous nephropathy, it's important to give the patient antiprophylactic. And then what are our target to be the albumin more than 30 in case of membranous nephropathy. In other nephrotic syndrome, if less than 20, and some guidelines said between 20 and 25. What are our options? We can give him Clexane or NOAC. Both can be used. In case of hyperlipidemia and and hypothyroidism will be corrected after the treatment of a primary cause of nephrotic syndrome. حد عنده سؤال يا شباب؟ Okay. So we start with minimal chain disease, which is, as you know, this is the most common cause of nephrotic syndrome in pediatric population. Also, third most common cause in nephrotic syndrome in adult. What are our causes of nephrotic syndrome? Usually primary, but you have to rule out secondary cause of nephrotic of MCD. So Hodgkin and Hodgkin lymphoma, medication like NSAID, infection like syphilis, HIV, and autoimmune disease. Okay, as we said, the diagnosis of nephrotic syndrome should be by biopsy. So you have to understand the biopsy. In case of minimal chain disease, will be normal. So the biopsy for the light microscopy and immunofluorescent will be normal. Difference will be in electron microscopy. There will be diffuse food process effacement. As we said before, it's called photocytopathy. Photocytopathy, sorry. So there will be diffuse food process effacement. This is a main finding in case of a minimal change. Otherwise, will be normal, completely normal. What about FSGS? We'll come to the FSGS. The difference will be in light microscopy. There will be one glomerulus at least will be sclerosed. This is just a terminology used in the glomerulonephritis to just understand what is focal, what is diffuse. So focal affecting some, but not all the glomeruli. Diffuse more than 50% of the glomeruli. Segmental portion of the glomerulus only. Global affecting all of the glomerulus. So what about the treatment of a minimal change? So the main treatment, the first line of a treatment should be prednisone. What is the dose of prednisone? Should be 1 milligram per kg. Here it's maximum, the guideline maximum is 80 milligram, but we are not giving 80 milligram because side effects of steroid. So usually we are giving the patient 60 milligram. What are the duration? At least 4 weeks. So please, for the minimal change at FSGS, if you're starting prednisone, you have to start for at least 4 weeks. Even if there is complete remission, you have to continue at least 4 weeks. And then you will taper the dose of prednisolone. One tablet 10 milligram per week till we reach, for example, 20 and then 5 milligram. And this is depends on the doctor. So what about if the patient having another relapse? So meaning we are treating the patient, we give him full dose of steroid, and he's completely in remission for give him total course of, for example, four weeks, and then another tapering dose till 5 milligram, and then we discontinued. If the patient develop another relapse, first relapse, for example, we'll continue the same. We treat the patient as a first relapse. If the patient cannot tolerate corticosteroids or have contraindication of corticosteroids, we'll add what? CNI, calcineurin inhibitor. And you have two choices of calcineurin inhibitor, either cyclosporin or tacrolimus, Procraf. Here is some terminology of the membranous, of minimal change. We have steroid resistant, which failed to achieve remission within 16 weeks of steroid. We have steroid dependent, meaning that the patient relapse during steroid tapered. And we have frequent relapsing, relapse 2 times within 6 months. All of these are indication to start CNI, calcineurin inhibitor. Again, if the patient is unable to tolerate CNI, we can give the patient rituximab. Now it's the first line. Also, we can use rituximab as a case of in case of minimal change disease. For sure, in case if we are giving the patient prednisone, we have to give him what? PPI, calcium, and vitamin D. So we'll give the patient prednisolone, calcium, PPI, vitamin D. What else? Give the patient, if the patient is volume overloaded, we advise the patient for a fluid and salt restriction, along with Lasix if indicated. Of course, we give the patient prophylactic for the thromboembolism if the albumin less than 20. and we'll follow up the albumin level. More than 25, it's okay, خلاص, we can stop. Here's one example of one patient presented with a classic feature in my clinic, classic feature with nephrotic syndrome. So the patient started here. He has what? Heavy proteinuria, almost 5 gram. What else? Hypoalbuminemia 22, and he has significantly lower lipidemia. Here, what you can see here, in case here we have normal creatinine. It's less likely to be nephritic syndrome, and the urine analysis was normal apart from the proteinuria. So the patient was not having hematuria. So this is a feature of the nephrotic syndrome, which is minimal change or minimal change usually. Here also we have the patient have hyperlipidemia. After a course of prednisone 1 milligram per kg, it was 60, and we tapered the dose, and then finally the patient was in remission. So here you have the proteinuria is 150, and albumin is dramatically improved to 44, completely normal. The other one is FSGS. So usually presents with nephrotic syndrome, again with diffuse photoprocessed effacement, the most common biopsy diagnosed in United States, the most common glomerular cause of end-stage disease. So male to female incidence is 1.5 to 1. So what we can see in case, as I said, the biopsy is the diagnostic approach for such patient with nephrotic syndrome. In case of light microscopy, will be at least one glomerulus with lesion of segmental sclerosis. So I mean, in case of immunofluorescent, there is no deposition. Electron microscopy will have diffuse photoprocessed effacement. The difference between the membrane minimal change and FSGS is light microscopy. Of course, again, like in case of minimal change, you have to rule out secondary causes like infection, HIV, cytomegalovirus, Hodgkin and Hodgkin lymphoma, some drugs. It just just to show you that there is a histological subtypes of FSGS. This is important for the pathologist. For example, case of collapsing variant will be most likely poor prognosis, while in case of tip lesion, this is a good or best prognosis of FSGS. Again, this is one of my patient in the clinic. He was diagnosed with FSGS 10 years ago, but he lost follow-up. He diagnosed somewhere else, lost follow-up, but he was having diabetes and hypertension. So the patient already having CKD. So he's not candidate for immunosuppressive. How we can say this patient is most likely secondary, not primary nephrotic syndrome by looking to the albumin. So the patient is presenting with normal albumin, no lower limb edema, with the proteinuria is almost 3 gram. So I started with the patient with just give him losartan or ARB or ACE diet and exercise with weight reduction, and then because he has also uncontrolled diabetes. So after that, after 3 months of the management, conservative management, the proteinuria is improved to 250 from almost 3 gram. So what is the treatment of SGS? As we said, we have to rule out secondary causes, have to start the patient with a conservative, and of course, we have to start with the prednisolone. Again, the same approach of the minimal change. We start 1 milligram per kg, maximum dose is 60 or 80, and then taper the steroid dose. If the patient not tolerated or have the resistant, we can start CNI, either cyclosporin or tacrolimus. What about membranous? The most common cause of nephrotic syndrome. The primary account for 70%, so most likely is primary cause, while secondary is account for 30 to 40%. So what are the pathogenesis of this one? So here we have the antigen antibodies, which is called phospholipase A2 receptor. This is important for diagnosis of patient. If this one is present in the labs, so no need for biopsy. What are the clinical manifestation? Same as minimal change in FSH. The patient will present with classically nephrotic syndrome, so proteinuria. The patient will have risk of the renal vein thrombosis, as we said before. So thrombosis is more common in membranous, 70% compared to another nephrotic syndrome. So we treat the patient even if the albumin is less than 2.8. As I said before, we have identified antigen in case of the membranous. The most common one is phospholipase A2 receptor. Again, you have to rule out secondary causes, all of nephrotic syndrome, autoimmune disease, infection, etc., medication induced. What about the renal biopsy in case of membranous? We'll have a light microscopy, we'll have thickened glomerular capillary with the spikes. In immunofluorescent, we'll may have some deposition of IgG and C3 granule staining. In electron microscopy, we'll have subepithelial deposit. What about the treatment? So sort of the one third of the patient undergo spontaneous remission, one third develop persistent proteinuria, another developed CKD. We'll start the patient with AS or RB, and we'll treat the secondary causes, and then we'll reevaluate the patient. If the patient having persistently elevated proteinuria, persistent more than 4 grams, we have criteria, but it's not important to know it now. So we start the ACE and the RB if the patient having persistent proteinuria more than 4 grams, and also we are also judging about the phospholipase A2 receptor titer. There is some indication to start immunosuppressive medications along with the rituximab or steroid. The important one is here. So don't start glucocorticoid immunotherapy alone. So should be combined with CNI or another agent. As I said, the anti-phospholipase A2 receptor antibody titers may be used to monitor response to therapy. Even also the remission of disease. أي سؤال يا شباب عن النفروتك؟ Okay. So moving to nephrotic syndrome. As I said, how we can differentiate between nephrotic and nephritic syndrome. Most of the time, nephritic syndrome will present with hematuria. So if you do urine analysis, you will find hematuria, RBCs. So most likely be dysmorphic RBCs. This is coming from the glomerular. Hypertension also may present and AKI. What about the proteinuria? Usually will be less than 3.5. Okay, since the hematuria is a cardinal feature of nephritic syndrome, not always hematuria equal nephritic syndrome. So please, we have to rule out other causes. So we have glomerular causes, which is most common cause, what IgA nephropathy, thin basement membrane, and Albert syndrome. The most common cause of the glomerular cause of the hematuria. But we have non-glomerular cause of the hematuria, for example, interstitial nephritis, papillary necrosis, pyelonephritis, polycystic kidney disease. What about non-renal, but urinary cause? We have trauma, BPH, prostatitis, etc. Malignancy also. So please, we have to rule out other causes of hematuria, not always the glomerular cause. What toward us to the glomerular cause? The patient will have proteinuria also. Proteinuria with hematuria most likely is a glomerular cause. While if the patient having hematuria without a proteinuria, so look for another cause. This is just to guide you how to can differentiate between other causes of the hematuria. For example, the patient having AKI, think about the as IgA nephropathy, RPGN, etc. The patient having CKD, think about the post kidney disease, recurrent upper respiratory infection, think about post-infectious glomerulitis or IgA nephropathy. Unilateral flank pain, for example, stone or renal infarction. Okay, this is important. So how we can approach patient with nephritic syndrome or hematuria? So does the patient having hematuria or proteinuria or both? If yes, so does the proteinuria more than 500 milligram? So we'll do the kidney biopsy and then we'll send for the secondary causes of the nephritic or nephrotic syndrome. If the patient having isolated hematuria, we have to follow up the patient. And then the most common cause of the isolated glomerular hematuria is thin basement membrane, Albert or IgA nephropathy. The important thing in case of nephritic syndrome, we'll do biopsy for the looking for the immunofluorescence. Important. So if the immunofluorescence there is minimal or no deposit, that's meaning the causes or differential. Our differential is GPA, microscopic meningitis, or other vasculitis. If there is linear deposit in immunofluorescence, So the differential diagnosis is anti-GBM or febrile nephritis. If the patient having deposit with immunofluorescent, but it is a granular deposition, we'll think of the SLE, IgA, and post-streptococcal nephritis. Also, the complement level will help us to make a differential diagnosis of the nephritic syndrome. For example, in case of IgA nephropathy, the complement will be normal, while in case of post-streptococcal will be low. Okay, I'll talk just in brief about the IgA nephropathy. So, the most common lesion found to cause primary nephritis. What are the clinical features of the IgA? So the patient may present from asymptomatic microscopic hematuria to RPGN. So just remember that IgA nephropathy can end with RPGN or end-stage. So we have gross hematuria. Most of the patients come to the clinic with a gross hematuria. Just think of IgA. So 40 to 50% of the patient with gross hematuria, while microscopic hematuria with or without proteinuria. So this just we are finding this hematuria in urine analysis, routine urine analysis. The patient completely asymptomatic, just came for routine follow-up or whatever urine analysis, and he found accidentally finding that he have hematuria. So this is present in 30 to 40% of the patient, while nephrotic range less than 10%. What about the acute kidney injury? It's rare or with or without oliguria. So the diagnosis of IgA should be suspected in any patient who present with one or more of the following, as we said, one or more episode of gross hematuria, especially if combined with upper respiratory infection, persistent microscopic hematuria with or without proteinuria, and slowly progressive kidney function impairment. How we can establish a diagnosis? Again, with renal biopsy. All nephrotic and nephritic syndrome, we have to do renal biopsy. Unless if the patient presented with phospholipase A2 receptor positive more than 20, and then we can make diagnosis of membranous without taking a biopsy. And some of genetic disease like Albert syndrome, etc. If you are doing gene testing, no need for biopsy. But in general, biopsy is important. The diagnosis of IgA by the biopsy, patient will have deposition of the IgA and mesangial expansion in light microscopy. Okay, what are the risk factors for disease progression? So the risk factor is if the patient having proteinuria 1 gram, hypertension, or reduced GFR, or histological prediction of prognosis. So from the prognosis from the better to worse, if the patient having episodic microscopic hematuria, so better than gross, better than persistent hematuria plus proteinuria, and the last one is hematuria with the proteinuria more than 1 gram is the worst prognostic factor in IgA nephropathy. So what is the treatment of the IgA nephropathy? Usually is conservative. So we start the patient with ACE or ARB, and then we'll follow up the patient. Our target is the proteinuria should be less than 1 gram. So we start, for example, we start with lisinopril 10 milligram. And if the patient, again, we'll give the patient time for 3 months, and then again return to the clinic. If the patient having still proteinuria more than 1 gram, what we'll do, we'll just increase the dose. For example, if he's taking lisinopril 10 milligram, we'll give him 20. Losartan, for example, 50, we'll give him 100. So we are reaching maximum dose of the maximum tolerated dose of the ACE. Of course, we have to check blood pressure also. So if the patient still having proteinuria despite maximum dose of ACE or ARB, we give the patient SGL2 inhibitor. And then, of course, for weight reduction, exercise will help. And then we'll evaluate the patient. If still having persistent proteinuria more than 1 gram, maybe we'll consider steroid in such patient. We'll do risk stratification. For example, if the patient having GFR more than 30, and if he indicated for steroid, does not have, for example, he's not obese or is not having diabetes, maybe consider. And we have also another medications like sparsentan and others, but study ongoing. طيب في سؤال يا شباب قبل ما أسألكم. طيب. Okay, this is a 40-year-old white woman present with a sudden onset of facial and lower extremity edema. She had been in excellent health on no prescription over-the-counter medications. A review of systemic was unremarkable for rash or arthralgia or oral ulcer. On examination, blood pressure was maintaining. She had facial swelling and pitting edema extending to the thighs and involving the sacrum. So serum creatinine 1.5, so 1.5 milligram, or we can convert it, just multiply by 88. So serum albumin is 1.4. So the patient having hypoalbuminemia, serum cholesterol is 600. So the CBC was normal. Urinalysis is 4 plus protein. 24-hour urine collection is had 20 gram of protein. So renal biopsy demonstrating minimal change disease with acute tuberous necrosis. So what do you think the best therapeutic option for this patient? A, to manage conservatively, give the patient sodium, fluid restriction, whatever statin, Lasix, and then wait for spontaneous remission. Or, in addition to that, we'll start with cyclophosphamide with the highest dose steroid. Or C, cyclosporin with high dose prednisolone daily. Or we'll start with rituximab and high dose prednisolone. Or high dose prednisolone daily or on alternative day. طبعا دائما شباب بحالات الام سي كيو انتم عارفين يعني تبدون بالبدايه بالسؤال نفسه يعني نهايه السؤال يعني what is the best therapeutic management بعدين تقرون السيناريو. ايش رايكم؟ طيب ليش طيب ليش الاغلبيه اختاروا A؟ ان احنا بحالات النفروتيك syndrome minimal change or FSGS you have to start steroid. So steroid is the first line of treatment. Patient will not go in remission if you didn't start steroid. So steroid first. So in case, so start of course conservative treatment along with high dose steroid. واضح ولا في أحد عنده سؤال؟ دايم بحالات minimal change FSGS you have to start steroid along with a conservative management. Don't stop for spontaneous remission. Maybe membranous if the patient having can start ACE and then follow up the patient. IgA also follow up the patient. But in minimal change and FSGS have to start steroid. Okay, طيب سؤال ثاني. So the question here, what is the best therapeutic option? طبعا أنا بختصر لكم السؤال أنا عشان سؤال طويل شوي. 32 black present with the sudden onset of lower extremities edema, creatinine 1.8, albumin 20, so he's having hypoalbuminemia. Urinalysis is 4 plus, you're having proteinuria also. 24 hours 10 gram, no family history of disease. He's not obese. In examination, he's having hypertension. So the secondary causes of nephrotic syndrome, including complete secondary cause was ruled out, and then kidney biopsy demonstrate FSGS. Immunofluorescent is negative. Okay, so the patient was placed on furosemide and ACE inhibitor with some improvement in his blood pressure and lower extremity edema. Additionally, he was placed on high dose steroid. As we said before, in case of nephrotic syndrome, in case of minimal change of FSGS, you have to start high dose steroid. So the patient started conservative treatment along with high dose prednisone, but he continued to have a proteinuria of 80 grams. So he started with 10 gram and now 80 gram. So there is no much improvement. So, but continued to have proteinuria of 80 gram despite being on high dose of prednisone for 16 weeks. So what do you think now the next therapeutic option for this patient? So A will continue high dose prednisolone for another 1 to 2 months, or will start cyclophosphamide and tablet prednisolone, or cyclosporin in combination with the low dose prednisolone, Tilsipt and tablet prednisolone, or rituximab. أعطيكم 30 ثانية. طيب أغلبكم اختار بي. طيب ليش بي؟ أنا ما جبت طاري سايكلوفوسفاميد أبد ترى بالمحاضرة. طيب احنا قلنا قبل in case of nephrotic syndrome you will start prednisone conservative treatment of course along with the prednisone 1 milligram per kg. If the patient still having prednisone, if the patient still having proteinuria despite maximum dose of prednisolone, this is what does it mean? Steroid resistant, right? So in case of steroid resistant, what we will start? CNI, right? So in CNI, what does it mean? Cyclosporin. Cyclosporin or Prograf can be used along with the low dose of prednisone. Of course, we'll not continue high dose of prednisone now because the patient having now 16 weeks on prednisone without any improvement. What about cyclosamide? That's indicated in case, and tablet off, it's not indicated in case of the FSGS. What about Silsibt? It's inferior to the CNI. Rituximab, it's not now. Can use it as a third line. So the answer is what? C, as I said. في أحد سأل قال وش التشخيص؟ قصده إيش؟ أي سؤال؟ طيب كل الحالات السؤال الثاني diagnosis steroid resistant FSGS. So in case of steroid resistant, so we'll start the patient with the CNI. The first one also minimal change. The diagnosis was minimal change, and the main treatment of minimal change is to start high dose steroid. السؤال الثالث, so which is not a therapeutic option. طيب هذا باختصار. This case is membranous nephropathy. So 65, presented with nephrotic syndrome 6 months ago. He was normal blood pressure. Serum creatinine is 1, albumin is 2, so he was having hypoalbuminemia. 24-hour urine collection was 10 grams, so significant. Proteinuria, proteinuria. So we are thinking of a 3, minimal change, FSGS or membranous. So workup was all negative. So serum antiphospholipase A2 receptor was elevated, 200. So this is toward the diagnosis of what? Membranous. Okay, so the kidney biopsy demonstrated membranous glomerulonephritis. Okay, so the patient was placed on ACE, as we said. You have to start ACE for the patient over the course of the 6 months. Although there was no, also there was improvement in the edema, but he continued to have proteinuria, heavy proteinuria. So we start the patient with conservative treatment, but again, he's having heavy proteinuria despite conservative treatment. We present again to the clinic after 6 months with 80 grams. What will do for such patient? What do you think the option of this one? So which is not correct here? Either prednisone alone, tacrolimus with low dose of prednisolone, prednisolone alternative day with cyclophosphamide, or rituximab. تمام. So as we said before, please don't start prednisone alone in case of membranous. So all are can be option for such patient with membranous, except for prednisone alone. So regarding the treatment of nephrotic syndrome due to primary FSGS, which of the following statement is correct? Corticosteroid have been the first line therapy at 1 milligram per kg per day. CNI are generally used as a second line of agent. Tuximab can enhance remission. Silsept is likely inferior to CNI or all of the above. تمام. ايوه صح. all of the above. Okay, which of the following condition is not associated with FSGS? Morbid obese, hep C, sickle, HIV. ولا واحد اختار بي يعني. So the answer is B. So you have to remember the secondary causes of nephrotic syndrome, either FSGS or minimal. Hep C also not presented to FSGS, usually presented with membrane proliferative. Okay, I talk about the phospholipase A2 receptor. So which of the following statement regarding anti-phospholipase A2 receptor antibody and membranous nephropathy is correct? So this one titer correlate with disease activity, provide prognostic information about severity of the disease, and serve as a useful biomarker for assessing treatment efficiency. B, occurrence of spontaneous remission is more common in patients with low antibody titer compared to the high titer. So high antibody titers are associated with a lower response to immunosuppressive or anti-phospholipase A2 receptor titer may also predict progression from the non-nephrotic proteinuria to nephrotic proteinuria all or of the above. طبعا هذا ممكن قليل يسألونك عنكم كميديسن لكن كمعلومة عامة يعني عشان تعرفون. طيب في بعضكم اختار A. طيب B بعد ترى جواب صحيح. بشكل عام انتي فوسفوليبيز A2 ريسبتور نقدر نستخدمه as a prognostic factor or follow up the disease progression, or even if the patient have a lower titer is more likely to help in disease progression, in less disease progression than higher titer. So the answer is E, all. Patient with primary or membranous nephropathy and nephrotic syndrome are at increased risk for venous thromboembolism event. Which of the following statement is a risk factor for VTE? رايكم. A 3.8, B 3.5, C 3.2, D 3, E 2.2. طيب طيب اللي قال A ولا B؟ طيب 38 طبيعي ألبوم نورمال، و 38 is normal 35 is normal. So no indication to give the patient prophylactic thromboembolism for the hypoalbuminemia. In case of membranous, if the albumin less than 2.8 يعني في أقل من 28. بشكل عام النفروتك سندروم من 20 إلى 25. membranous شوي نرفع يكون 28. لكن 38 35 أصلا هذا طبيعي. الجواب الصحيح هو إي. طيب 62. So which of the following is the next best step in managing this patient? He is a 62 um, man is seen in your clinic for evaluation of nephrotic syndrome. Workup reveals serum creatinine 0.8, albumin 3.2, 3.4 gram proteinuria, division 133 over 82. Additional surgical workup reveals the phospholipase A2 receptor positive at 35. So what do you think the best next step management of this patient? So should this patient undergo kidney biopsy, or will start immunosuppressive for the patient, CNI like cyclosporin, etc., or rituximab, or will initiate ACE, either linezolid, enalapril, or the ARBs like losartan or valsartan? What do you think the answer? طيب ممكن أحد يتداخل معي صوتيا ليش اختار دي؟ طيب تذكرون ايش قلنا عن الممبرينس؟ هذه غالبا تشخيص وشو ممبرينس. انا ذكر لك هنا فوسفوليبيز اي 2، احنا قلنا فوسفوليبيز اي 2 غالبا تكون ببرايمري، اذا هي بوزيتيف فمعناتها برايمري ممبرينس not secondary cause. تمام. طيب هنا بوزيتيف، خلاص معناته هل المريض يحتاج بايوبسي؟ قلنا احنا قبل اذا المريض بوزيتيف فوسفوليبيز اي 2 ما يحتاج بايوبسي، معناته عنده برايمري ممبرينس ما نحتاج بايوبسي. تمام. طيب البروتينيوريا عنده كم؟ تقريبا 3.5 جرام، يعني حتى ما هي هيفي بروتينيوريا. شو نسوي؟ طيب وات از ذا نيكست ستيب اوف مانجمنت؟ نحتاج بايوبسي؟ ما نحتاج بايوبسي الا اذا في ريزيستنت تريتمنت. از فيرست لاين مانجمنت نبدا بايس مباشره. ليش نبدا بيون سبريسيف ميديكيشن؟ ليش نبدا على طول تكسيماب؟ مريض عنده نفروتك سندروم جاي. بشكل عام مستحيل مريض اول مره شخص المريض نفروتك سندروم ابدا ريتوكسيماب، ابدا. ما تبدا ريتوكسيماب از فيرست لاين اوف تريتمنت. هذا المريض جايك للعياده، جاء العياده سوى تحاليل واكتشف ان عنده فوسفوليبيز اي 2 ريسبتور بوزيتيف 35، معناته من برينس. ليش ابدا ريتوكسيماب؟ ريتوكسيماب اصلا متى يشتغل؟ لا تبدون ريتوكسيماب يعني على الاقل لو حط الستيرويد ما عندي مشكله، بس ريتوكسيماب ولا مينو سبريسيف لا، اصلا كل ذول سين ريتوكسيماب راح ياخذ وقت على بال ما تشتغل. احنا الفكره حتى لو المريض مثلا جاك ممبرين مثلا مينيمال تشين ديزيز وجاك بريلابس مره ثانيه مثلا بريلابس، وراح تبدا سيناي، تبدا سيناي مع ستيرويد، لان السيناي راح ياخذ وقت اصلا على بال ما يشتغل. treatment is or what will do. So this is confirmed diagnosis of membranous because positive of phospholipase, so start ACE. وبعدين نراقب المريض حد بعدين نشوف يحتاج ولا لا. لكن بعد 6 شهور الى الان persistent proteinuria 4 جرام والليفل اوف phospholipase is high, so we can initiate immunosuppressive medication. لكن الان طبعا هذا اقراه لكم عشان so the patient is presenting with nephrotic syndrome, normal kidney function, serologically is positive for phospholipase. Medicine obtaining kidney biopsy will only confirm that the diagnosis of membranous will not change the management. طيب which of the following observations is suggestive of glomerular hematoma؟ مثل ما قلنا احنا قبل بالجدول there is a differential diagnosis of the hematuria either from the glomerular cause, non-glomerular cause, we have um, from urological cause, etc., vascular cause. Which of the following is toward the diagnosis of glomerular cause hematuria? He has 20. He has found to have the isolated asymptomatic microscopic hematuria on routine physical examination. So what do you think? A, presence of the isomorphic RBCs. B, isomorphic RBCs with white blood cells. C, dysmorphic RBCs. D, decoy cells in the urine sediment. All, all of the above. طيب 4 منكم قالوا all of the above. طيب ليش؟ احنا قلنا بحالات الجلوميريكوز هيماتوريا المريض راح يكون عنده ديسمورفيك ار بي سي صح؟ فاهم ديسمورفيك ار بي سي جلوميريكوز. طيب هذه ايزومورفيك؟ لا ما هي جلوميريكوز. if جلوميريكوز will be dysmorphic RBC not isomorphic RBC. طيب uh, so this is 67-year-old. The biopsy demonstrating IgA nephropathy with hematuria and urine analysis. Creatinine is 0.9 milligram. He has microalbuminemia of 600 milligram. Blood pressure is 119 over 80. He is on losartan 100. So on the basis of the current data, what is the next step? What is the next best course of a treatment? So this patient diagnosed with IgA started losartan 100. Proteinuria is 600 milligram now. So what do you think the best step? So A, we will add dapagliflozin, which is GL2, or we'll do nothing for this patient, or we'll add diuretics, or lisinopril. قلتها بالشرح. طبعا المريض بالعادة نعطيه فرصة 3 إلى 6 شهور بعدين نشوف البروتين. إنه هو معناته بدأ بالبداية 50 ملغ as a first line of ACE and then we increase the dose to 100. بعدين جانا ب 600 ملغ بروتين. يعني طيب patient is still having proteinuria 600 ملغ is a proteinuria it's more than 150 or 300 ملغ. So the patient have still persistent proteinuria despite ACE. احنا نشوف medication قلنا احنا ACE or ARB and we will give the patient maximum tolerated dose of ACE or ARB. طيب هو الآن ياخذ لوسرتان 100 خاصة maximum. If for example losonoprazole will increase the dose and follow up the patient. طيب the answer is A. So as we said before we can add STL2 in such a patient. طبعا lisinopril لا إنما هي the patient already on losartan he already on ARB we will not add ACE for this patient. High risk of the AKI and hyperkalemia. So never combined ASO and ARB together. Okay, this is 43, a year-old man. The question is, which of the following is the next best step in management? So he's 43-year-old, present with to nephrology clinic with ongoing management of IgA nephropathy. Again, IgA nephropathy. So 4 months ago, he has microscopic hematuria and proteinuria were detected during the insurance evaluation. The blood pressure 135 over 85, 24 hour is 1.1 gram for protein. Serum creatinine 0.9. Kidney biopsy demonstrated IgA nephropathy. So he was started on lisinopril 20 milligram. was initiated 1 month ago. If the patient feels well, so he came again with to the clinic with blood pressure 130/78. Physical examination unremarkable. So proteinuria still 1.2 gram. So we started the patient, or we started with lisinopril 20 milligram, and then again the patient presented to our clinic with 1.2 gram. What we'll do for this patient? A, will prescribe losartan. B, will repeat 24 hour. C, will increase the lisinopril dose. D, not do anything for this patient. E, will prescribe amlodipine. What do you think? مشابه للسؤال اللي قبل. اي جي اي بدينا ليزونبريل 20 وجاء العياده 1.2 جرام، واساسا كان اصلا تقريبا فوق، تقريبا كان 1.1 جرام. ايه تمام. ومثل ما قلنا احنا لازم تقريبا تعرفون اغلب الادويه يعني وش الماكسيمم دوز. ممكن نبدا احنا 10 20 30 40 ليزونبريل. شو مثلا لو سرطان، تلمي سرطان، بال سرطان، كاندي سرطان يعني. all of ACE or ARB you have to know the maximum dose of medication. فمثل ما قلت answer is lisinopril. طبعا انتم بالنسبه لكم بالميديسن ما راح تجيكم الاسئله تقريبا اللي انا قلتها قبل شوي، بعض الاسئله شوي ادفانس بالنسبه لكم، بس كنت تفهمون الفكره العامه بحاله النفروتيك سندروم. how can approach patient with nephrotic syndrome, how we can differentiate between nephrotic and nephritic syndrome. بس هذا اغلب شيء بالاختبار راح يجيكم بشكل مبسط يعني. انه what is the most common cause of this patient of nephrotic syndrome, either minimal change or FSTS. يجيكم سيناريو عن مثلا اي جي اي نفروباثي، راح تكون واضحه يعني. يقول لك مثلا لات ميكروسكوبي كان عنده ميزانجيال اكسبانشن، عنده اي جي اي دوبوزيت. جاك مثلا تريتمنت اوف مينيمال تشينج، تقول هاي دوز ستيرويد فول اب ذا بيشنت. ان شاء الله الاسئله ما راح تكون ما راح تكون معقده باذن الله. الله يعطيكم العافيه والله يوفقكم ويسهل امركم باذن الله، والنجاح جميعا. احد عنده سؤال؟